Thank you for the opportunity to present on this topic of diagnostic imaging to evaluate transcatheter edge-to-edge repair therapy for heart failure patients. These are my disclosures. For the next 10 minutes, I want to work on an identification strategy for evaluating which patients are suitable anatomically for TEER using imaging. Number one, we're going to focus on defining the different types of anatomical challenges that exist in doing edge-to-edge repair for MR. And number two, we want to extend into what the algorithm could potentially be for doing risk stratification for patients who are presenting for edge-to-edge repair. Same with the different types of anatomical challenges, we have to first understand the device design. Focusing on the most commonly used device right now, that would be the MitraClip G4 system. You want to learn about device profile, device clip length, and the device anchoring mechanism. This is crucial for understanding not just by the implanter, but equally also by the interventional imaging physician. The information involved in learning this regards on the length of the actual clip arms. For the G4 NT and NTW, is actually 20 millimeters from the edge to edge. And for the XT and XTW, the length from clip edge to clip edge is 25 millimeters. This is extremely important when picking which device is best for your patient's anatomy. What else is additionally important beyond the clip length and the width is actually understanding the frictional elements. Frictional elements is something we don't commonly think about when we're looking at doing any kind of edge-to-edge repair. The concept of the frictional elements actually began with looking at how the clip is designed. In the bottom left-hand image, you'll see that the clip arms actually have a frictional element of 9 millimeters in the blue in the XT and XTW. In the NT and NTW system, the actual frictional elements are 6 millimeters. This refers to where the teeth are for the actual clip arms. The clip arms are dropped. This actually then translates to what the leaflet length minimally needs to be for successful actual capture of leaflets without risk of single leaflet detachment in the actual clip system. Now that we understand the clip design, we should go to optimizing imaging anatomy for edge-to-edge repair. There are three key patient anatomies that are very challenging for doing edge-to-edge repair. The first one will be the patient with a short tether leaflet. The second one will be the exact opposite. A patient with a long redundant leaflet is also equally challenging. And number three will be a patient that has a commissural MR leak. Let's go through them one by one. So for the first challenge, as you can see, patient on the left has a great leaflet length of 9.9 millimeters and will be a go. However, patient on the right would not be an easy case. The red arrow shows you the P2 posterior leaflet, although it has some length, the tip of it is actually tethered, and this is going to prevent it from falling completely flat on the clip arm and will be a challenging anatomy. Now, going to case one, how can we make this a successful case if you have a tethered posterior leaflet? When we first grasp, what you want to look for in the posterior leaflet is that the leaflet tip and the leaflet body is not knuckling on the clip arm. If the leaflet tip and leaflet body is knuckling on the clip arm, you'll see a lot of independent motion on the posterior leaflet when the clip arms are drawn. And this has a high risk for single leaflet detachment. So instead, to optimize this, what you want to do is take a look at the image on the left, make sure the leaflet tip is not knuckling. And so on the patient, when we're doing this, we actually shift the whole system more posteriorly and we get the complete leaflet body inserting into the middle of the actual clip arm. And this will actually be good because we have more leaflet length and we don't have any knuckling. When that occurs, you can see that the clip, when it actually is closed, you have very little to minimal mobility of that posterior P2 leaflet, and then you have trivial MR at the end. So that's the trick number one. Anatomical challenge number two also exists when you have plenty of leaflet length. In this patient, we have over 11 millimeters of leaflet length. If we were actually playing the TEE, you can see there's a rupture chordae, and the leaflet is much more redundant, and there's much more to be used too. This is a big dilemma in itself. The reason being is that when we look at this, we have learned that we don't want to just grab leaflet. What you can see is the hinge point of the leaflet on the far left-hand screen is actually external to the actual clip arm length. You can try to close, as we did right here, but what you will likely do is get a risk of leaflet perforation, or you'll get a simultaneous independent judge right to the medial or lateral portion of where that leaflet is still very mobile because the hinge point was not captured. How can you optimize this challenging case? Well, on the left-hand image is what we don't really want to do, and that's have the hinge point outside the leaflet body. So we slide the system more posterior on the right. As we do that, notice that the leaflet hinge point actually falls on the body of the actual clip arms, as we can denote right here. When it does do that, you can have minimize of the motion of that posterior leaflet body, and it will be maximum potential of capturing that leaflet. Hence, when we're closing it, you can see the hinge of that leaflet body being captured in the actual clip and reducing the final MR grade down to trivial. Now, anatomical challenge number 3 requires a little bit of spatial understanding. On the far left-hand image is the intercommissural view of the mitral valve. Now, what you can see is that there's A3P3, A2P2, A1P1, or where there's theoretically supposed to be, and the X-plane image on the far right through the center of this will be A2P2. The concept is anything in the commissures is going to be anatomically challenging for any kind of delivery system. The reason being is where the red arrows are on the top left-hand image. Subcortical apparatus is very extensive in the commissural regions. It's actually the most extensive and most challenging in the A3P3 region and least in the A1P1. On the far right-hand image in the 3D surgeon's view, you can see where we label for you the aorta at 12 o'clock, A1P1 going to be at 9 p.m., and A3P3 at 3 p.m. Anything that's going to be extremely medial is going to be increased in procedural complexity because it will have less guide across the left atrium and will have a higher risk of getting trapped in the portal apparatus subvalvular in the left ventricle too. So what can we do to minimize our risks? Very simply, you can utilize Live 3D. It's a common knobology available on all machines. And you can actually do Live 3D, putting the left atrium at 12 p.m. and the left ventricle at 6 p.m. And the double orange arrow shows where the intra-atrial fossa is at. You can see where your guide sheet is at all times, and you see the trajectory vertically in a Live 3D pattern of going to the left ventricle. This allows you to visualize the subcortical apparatus and prevent entanglement while you're entering the left ventricle. Another trick is if you don't have access to Live 3D, you can also just do biplane imaging. So if you start in the LVOT view in the far left-hand image, draw a line and biplane through that, you can see the intercommissural crossing view too. Things that you want to look for when you're entering the LV is that you want to avoid entering the commissures. But if you do enter the commissures, there are 3 things you want to look out for to tell me that you are trapped. Number 1, the delivery system, as you can see in the far right-hand image, matches the motion of the left ventricle and the leaflets. It's a sign that you're stuck somewhere. It could be either chordal interference, or it could be a sign that somewhere your delivery system has extra torque stored in the left atrium. If any of these occur and you are bouncing with the heart rate, you should try to invert and return to the left atrium and enter at a different location. But what about an algorithm for doing edge-to-edge repair patient risk stratification? Now that you know how to overcome the difficult anatomical challenges, how do you actually identify what your prioritization of patients? This is an algorithm that I have designed at Henry Ford Hospital, and it basically focuses on imaging stratification and also safeguards success. So the concept is broken down by number 1, mechanism of failure, number 2, anticipated risks, and then a bailout strategy for every single risk, and then define success for these patients. So imaging stratification started with mechanism of failure. Failure and prolapse are more common and are challenging, and A2P2 are easier to attempt than A3P3. So those are risk stratification. If we have a patient with an LVE less than 30%, or a patient with RV dysfunction, or more than one segment involvement with MR, those are high-risk patients. So safeguards of success for those high-risk patients, we want to do those as first cases in the morning. We want to make sure we have an ICU bed available, and we have midodrine or any kind of pressure support, milrinone, or any kind of pressure support available in anesthesia cart, and mechanical circulatory support on standby in case something was to be going wrong. When we're looking at strategy and bailout, we want to look at baseline mitral mean gradient for these patients. So we know that if we go in, we have a pre-specified number for the mitral mean gradient that we do not want to exceed for that specific patient. And our definition of success is going to vary depending on what the patient's goal is going to be. We want to look at see what the grade is going to be okay based on, are we trying to bridge this patient to a surgery, or are we trying to bridge this patient out of extubation, or get them home with a better quality of life. All of this comes with clinical boundaries and clinical experience. The reason we emphasize LVE of less than 30% in the presence or absence of RV dysfunction stems from our learnings from this specific case in 2021. We learned that FMR patients have very little reserve. The patient on the left on February 4th was their screening TEE. We found severe MR. We can anatomically do this patient, and they came back 20 days later for their mitral clip. As you can see in the far right-hand image, the RV has severely dilated. There's severe RV dysfunction. I have smoke in the left atrium and the left ventricle. They did not get a mitral clip. This patient, as you were looking at the actual images when we dropped the probe, they were having sludge formation of left ventricle, aorta, and the left atrium, and emergently had to go actually on ECMO. FMR, 20 days presentation differences. FMR patients have very little reserve, and we have to do them as quickly as possible. But when you intervene at first diagnosis of MR after they are on GDMT, you can have a very successful case. This case, we started at 9:09 in the morning. At 9:36 a.m., we had transeptal crossing. We got into LV. We confirmed all leaflet bodies were in the mitral clip. At 9:38 a.m., we had trivial MR left and clip with implant. So in summary, imaging stratification is not truly imaging. It's about a strategy for success in understanding the clip device, clip design, and the whole delivery system sheath. What we need to focus on is no longer is color Doppler flow, MR quantification, and it's beyond the identification of the jet and localization of it. It's now how do we navigate to the point of interest. The most important concept is for interventional imaging physicians and implanters to learn the device, because then is only the way we can have imaging success. Thank you very much.